Welcome everyone to this addendum lecture on leptospirosis, specifically designed for the IS lecture series. I'm Miss Merle and I'm delighted to guide you through this important topic today. Leptospirosis is a crucial subject, especially given its global impact. We'll explore into its nature, causes, and implications soon. This session is structured to provide a comprehensive understanding, setting the stage for a deeper dive into its clinical presentation and diagnostic challenges. Remember, your questions and insights are invaluable, so feel free to jot them down as we proceed and let's embark on this learning journey together. Leptospirosis is a significant zoonotic disease with the potential to cause epidemics, particularly after periods of heavy rainfall. It is caused by the bacterium Leptospira, specifically Leptospira interrogans, and this bacterium is pathogenic to both humans and animals and boasts a staggering diversity with over 200 serologic variants or reservoirs. And this diversity is key to understanding why leptospirosis can be so widespread and challenging to control. While it may seem daunting, recognizing the potential for outbreaks helps in preparing and responding effectively. As we move on, we'll dig into the clinical presentations and diagnostic challenges of this disease. So, leptospirosis presents a unique challenge due to its unspecific clinical symptoms, which often leads to misdiagnosis. It is crucial to rely on laboratory results for accurate diagnosis. So the laboratory diagnosis can be quite challenging. So let's highlight two key diagnostic tests. So we have MAT and PCR. So first, the MAT, micro or microscopic agglutination testing. It is the gold standard according to the World Health Organization. It's the gold standard test for detecting leptospirosis in a patient. It detects antibodies specific to the Leptospira bacteria. However, it is important to note that this test is generally restricted to reference laboratories due to its complexity. Secondly, we have PCR. So there's this PCR. So this test is both sensitive and specific, providing accurate results during the acute phase of the disease. Unfortunately, PCR isn't widely available in many endemic areas. So understanding these diagnostic challenges is essential for improving our approach to managing leptospirosis. So let's take a brief journey through the history of leptospirosis and recognizing the contributions of Adolf Weil and others. So Adolf Weil reported the syndrome of icteric leptospirosis with renal failure in 1886. However, let's note that the disease was recognized much earlier, particularly in ancient China, as it's an occupational hazard for rice harvesters. Interestingly, leptospires were first visualized in autopsy specimens from patients who were initially thought to have yellow fever. And this discovery highlights the complexities of diagnosing infectious diseases in history. So, the role of the rat as a significant source of human infection was identified in 1917, which underscored the importance of understanding zoonotic transmission. So, knowing this history helps us appreciate the advancements in diagnosis and prevention over the years. So, now let's take a closer look at the bacteriology of leptospires. So leptospires belong to the order Spirocitalis, family Leptospiraceae, and genus Leptospira. So these bacteria are quite intriguing as they can be either pathogenic or saprophytic, meaning they live harmlessly in nature. And pathogenic leptospires have a unique ability to persist in the renal tubules of animals, making them a continual source of infection. On the flip side, saprophytic leptospires thrive in wet or humid environments, contributing to their widespread nature. Guys, remember understanding these fundamental characteristics helps us appreciate the complexity and adaptability of these bacteria in different environments. So let's investigate into the classification of leptospires. So the genus Leptospira is quite complex. It's divided into 20 species, classified into saprophytic, intermediate, and pathogenic groups. And these groups are essential for understanding both the biology and the public health impact of these bacteria. Historically, Leptospira was divided just into just two species, guys. We have Leptospira interrogans and Leptospira biflaxa. However, this has evolved over time. Now we use a genotypic classification system, and this modern approach helps us better understand the genetic relationships and epidemiology of these organisms. There are over 20 serogroups, uh, or no, over 24 serogroups and 250 serovars of pathogenic leptospires known to date. While the serovar concept is valuable for epidemiology, it does not have a taxonomic standing. So this shift to genotypic classification reflects a scientific progress, providing us with a clearer picture of how these species interact with their environments and hosts. So, leptospirosis, as we scour into its epidemiology, is noteworthy of being the most widespread zoonosis globally. It is an emerging public health concern, underscoring the need for increased awareness and preventive measures. Notably, leptospirosis is a global phenomenon, yet its incidence is notably higher in warm regions compared to temperate ones. So, this geographical variance provides insight into environmental factors of influencing its spread. Stunningly, we see over 500,000 severe human cases recorded worldwide annually. Regions such as the Caribbean, Central and South America, Southeast Asia, where the Philippines is uh, belonging to, and Oceania are particularly affected. These areas are considered endemic or even hyperendemic, especially in Southeast Asia, Southeast. So, highlighting the urgent need for targeted public health interventions. It's important to recognize that leptospirosis is predominantly a waterborne disease. This characteristic makes understanding local water management and hygiene practices crucial in combating its spread. So, under its epidemiology, numerous animals, primarily mammals, are sources of human infection. Rodents are the most important and widely distributed reservoirs of leptospires. Some reservoirs are associated with a particular species of natural maintenance hosts. In chronic infections, leptospires are localized in the kidneys, usually without detectable clinical manifestations. So the usual mode of contamination is abrasions or cuts in the skin or via the conjunctiva through direct or indirect contact with the urine or the tissues of infected animals. Other modes of contamination such as inhalation of water or aerosols, animal bites, and or interhuman transmission have been rarely demonstrated. So, leptospirosis is an occupational disease for veterinarians, farmers, abattoir workers, butchers, hunters, rodent control workers, and other occupations requiring contact with animals. So, indirect contact with contaminated wet soil or water is responsible for the great majority of cases in the tropics, either through occupational exposure, as in rice or taro farming, flooding after heavy rains, or exposure to damp soil and water during evocational activities. Also, contamination due to recreational exposures is increasing often with association with adventure tourism in tropical endemic areas. So on this slide, let's probe into the different epidemiological patterns of leptospirosis across environments. So in urban settings, it primarily spreads as a rodent-borne disease. This scenario is more common in temperate climates where fewer reservoirs are involved, and infection often results from direct contact with infected animals. Now, let's contrast this with tropical wet areas. Here, the situation is quite different. There are many more reservoirs that can infect both humans and animals, and a larger number of reservoir species are involved. This makes the disease harder to control and more widespread. So, understanding these patterns is crucial for developing effective prevention strategies and tailoring public health interventions to the specific needs of each environment. So, as we continue, we'll explore the clinical presentation of leptospirosis and its challenges in diagnosis. So, the clinical presentations, usually it may range from a flu-like illness to a serious, sometimes fatal disease. Confusion with other diseases, especially dengue fever and other hemorrhagic fevers, is frequent in tropical areas. The mean incubation time is 1 to 2 weeks, with a range of 2 days to 30 days. The acute or septicemic phase is lasting about 1 week, is followed by an immune phase characterized by antibody production. And the great majority of the infections are subclinical or very that of very mild severity. The most common symptoms are febrile illness of sudden onset, chills, we have headache, myalgia, abdominal pain, and this one, subconjunctival suffusion. Other clinical presentations may be predominant in addition to hepatic or renal dysfunction. Leptospirosis should be seriously considered in patients with pulmonary symptoms and fever, especially in subtropical and tropical areas, as reported in a retrospective study conducted in Taiwan. So, for the specimen collection, several blood tubes should be collected at the early phase of the disease. So, standard blood culture bottle or tubes, we have the non-additive or gel separator tubes for chemistry and serology, and EDTA for blood count. So, for the blood culture tube with heparin, to prevent clotting, it is recommended, but ideally, blood is inoculated directly into blood culture bottles containing culture medium for leptospires. So now here, let's go through the nuances of laboratory diagnosis with a focus on specimen collection for molecular testing. So research has shown varied results when comparing different blood components. Notably, serum has been reported as inferior to plasma, yet superior to whole blood. And then, interestingly, the Buffy coat often outperforms both plasma and serum in terms of effectiveness. So, a critical point to remember is that heparin can be inhibitory in molecular testing, so it's essential to consider this when planning tests. And also, it's vital to preserve all blood samples for potential additional testing. Acute blood samples are particularly important for serology to demonstrate seroconversion. These insights guides us in choosing the right specimens for accurate testing. So here, the various non-diagnostic abnormalities are reported in the table shown, and these things only suggest leptospirosis. Specific microbiological tests are also required for confirmation. So we have two types of analysis that can be performed. We have analysis of plural, right? So we have blood and urine. Under blood, we have leukocytosis with a shift to the left, thrombocytopenia in 50% of the cases, and elevations in ESR, creatinine, urea, aminotransferases, and bilirubin and ALP. In the urine, we can also observe proteinuria, pyuria, microscopic hematuria, hyaline, and granular casts. CSF fluid analysis also will show normal or slightly elevated CSF pressure. Uh, Initially, predominance of polymorphs or lymphocytes, and pleocytosis can persist for weeks. Protein elevations can also be observed. Glucose is usually normal, and xanthochromia might also happen. So here we'll discuss the specifics of microscopic determination in laboratory diagnosis for leptospirosis. Firstly, it's important to note that the direct examination of blood and urine is not recommended as a routine procedure, and this is mainly due to its low sensitivity and specificity. Also, misinterpretations can easily be confusing as we have fibrine strands or fibrine or protein threads for other elements. A key point to remember here is that leptospires are not visible under ordinary light microscope. Instead, we use dark field microscopy to observe them. Here, they appear as thin, coiled, and rapidly moving microorganisms. The sensitivity of dark field microscopy is worth noting. It requires approximately what's 10 to the 7, that's 10 million leptospires per liter to detect them effectively. While dark field microscopy offers unique insights, it comes with limitations that we'll explore further in the next sections. Let's proceed to discuss the staining methods available to enhance direct examination sensitivity. So here, leptospires are not stained. Remember this one, not stained by the conventional gram staining. Available staining methods to increase the sensitivity of direct examination are we have immunofluorescence, immunoperoxidase, silver staining, Warthin starry staining, immunohistochemistry, and in situ hybridization. All of these suffer from the same drawbacks as dark field microscopy, so which is it gives a high risk of false positive and false negative results. So for the isolation of leptospires, samples should be collected before antibiotic administration, as antibiotics can hinder leptospire growth. Also, timing is key because in blood culture, cerebrospinal fluid and dialysate within the first 10 days. Urine samples start from the second week. So the common culture medium, should not forget this one. Most commonly utilized culture medium is EMJH, oleic acid albumin, Ellen Gaussen, Macalo, Johnson Harris medium under BD company. And samples must be stored and transported at ambient temperatures with urine requiring immediate processing due to leptospire's limited survival in urine samples. Cultures are incubated in the dark at 28 to 30 degrees Celsius, examined weekly for up to 13 weeks before being discarded if non-viable. So that's the case for leptospire isolation. So here, this section focuses on antigen and antibody detection methods for leptospirosis, specifically the microscopic or microagglutination test or MAT. MAT, so established in 1918 by Martin and Pitet. MAT is the standard serological test involving the reaction of live antigens with serum samples and examining the resulting agglutination under dark field microscopy. So it's in combination with dark field microscopy for our MAT. However, the test is complex, and it requiring a comprehensive live antigen panel to avoid false negatives. Its dependence on live leptospires complicates standardization, making consistent testing challenging. So, in summary, while MAT is vital for diagnosing leptospirosis, its complexity and antigen panel requirements pose significant challenges for laboratories. So let's look into the timing and sensitivity of MAT for antibody detection in leptospirosis. So first, timing is crucial. Also remember that. And MAT may become positive around day 10 to 12 after the onset of the illness. However, if specific antibiotics have been used, this timing might be delayed. Now let's talk about sensitivity. Match shows varying sensitivity at different stages of illness. It's about 41% sensitive during the first week. This increases to 82% from the second to the fourth week. And beyond the fourth week, sensitivity jumps up to 96%. So these statistics highlight the importance of timing in testing. So next, the cutoff value. For the cutoff value for a single serum test is influenced by the seroprevalence in the population. So for example, we have a titer of more than 200 is used by the CDC for probable causes. In Taiwan, it's more than 100, and in Thailand, it's more than the titer is the cutoff is 400, more than or greater than 400. And in non-endemic regions, it's more than 1 is to 100. So in regions with high endemicity, A higher cutoff, like more than or greater than or equal to 800 or greater than 1600 or 1600, is necessary to be more frequent, necessary due to more frequent exposure. So finally, to confirm acute infection, a significant rise, specifically a fourfold increase in titer between paired sera, is needed or required, and this involves comparing samples from the acute and convalescent phases. So here we explore the ELISA, the enzyme-linked immunosorbent assay, which is a vital diagnostic tool for leptospires. ELISA detects antibodies reacting with a genospecific antigen, though it can specify serovar or serogroup. It is commercially available for many labs, and ELISA can identify antibodies as early as day 6 to 8, earlier than the microscopic agglutination test or MET, but may also turn negative sooner. And positive ELISA, guys, the results should be confirmed by MET for accuracy. IgM antibodies detected by ELISA can persist for months or years, complicating interpretation. Commercial test kits typically use the non-pathogenic Leptospira biflexa patoc strain as the antigen, and standard this is to standardize the process. Okay, and then for the rapid tests for the laboratory diagnosis, they have several advantages. So easy to use for non-specialists and portable, requiring no standard laboratory equipment, and can utilize whole blood for convenience. Many can be stored for ambient temperatures for long periods. However, they also have limitations. Some training is needed for accurate interpretation. There's also a variability in interpretation, and it can lead to inconsistent results. So these points emphasize both the benefits and challenges of rapid tests and diagnostics for leptospires. So this discussion here on this slide focuses on the limitations of rapid tests. Core limitations, particularly their target of detecting IgM antibodies, which are only detectable after the second week of symptoms. This poses a challenge during the early acute phase, leading to low sensitivity when patients typically seek treatment. And data from a multi-center evaluation within the first 10 days showed a mean sensitivity of 60.1%. Over 14 days, sensitivity varied across tests, which with IHA at 38.5 percent, and IgM dipstick at 52.7%. And these findings really emphasize the need to consider timing when selecting diagnostic tests during the acute phase, guys. So PCR is really a vital diagnostic tool that detects bacterial DNA in blood from disease onset to the 15th day, allowing early detection, especially within the first 5 to 10 days. So the typical bacterial load in serum ranges from what's that 100,000 to the 9, that's 1 billion leptospires per liter, indicating infection severity. PCR is beneficial even after antimicrobial treatment, as it can identify non-viable organisms in culture negative samples. And for leptospirosis, target genes used in PCR include universal bacterial genes. So we have GER-B, RRS, 16S rRNA gene, and SEC-Y. We also have the pathogenic specific leptospira genes, LIP-L32, LFB1, Lig or Lig A, and Lig B too. So these things ensure broad and precise detection. So future discussions will focus on real-time quantitative PCR and its advantages. So here, so let's dig into the real time, and this Q thing here, it's for quantitative PCR, which is a powerful tool for molecular diagnosis. So one of the key advantages of quantitative PCR is that it combines both amplification and detection in the same vessel. This integration offers excellent sensitivity and specificity, which are crucial in identifying pathogens accurately. Now let's talk about detection methods, we primarily use two techniques. We have cyber green and fluorescent probe technology, the TACMAN probes, which offers greater specificity. TACMAN. This one is highly sensitive, but it's less specific for the cyber green. So we've introduced specific qPCR assays tailored for different targets. For example, cyber green quantitative PCR targets genes like SECY or LIP-L32, and Pacman qPCR targets LIP-L32 or RRS16S. And furthermore, there's an exciting development with a multiplex assay that allows simultaneous detection and differentiation of pathogenic and non-pathogenic leptospires. This is a significant step forward in diagnostic precision. So, guys, these innovations in molecular diagnosis enhance our ability to really accurately and efficiently detect leptospirosis. So, here, let's talk about susceptibility testing and safety procedures when dealing with leptospire. So first, it's important to note that susceptibility testing is it's not routinely performed. Why? Because it requires a long incubation time, and accurately quantifying the growth can be quite challenging. And for the now on the safety procedures, these are crucial. So when working with leptospire, standard microbiological laboratory safety procedures are essential. We require biosafety level 2 facilities to ensure a safe working environment. So, does anyone have experience with these procedures? Or perhaps any questions about them? Safety is a community effort, and your insights are really valuable, guys. So here this is the way we can define what is leptospirosis in the clinical context. So leptospirosis burden epidemiology reference group definition of leptospirosis. Definitive case, so symptoms consistent with leptospirosis and any one of the following. Any one. So a four-fold increase in MAT titer between acute and convalescent serum samples. We have single MAT more than 1 is to 400, and isolation of leptospira species from a normally sterile site. Detection of leptospira species in clinical samples using histochemical or immunostaining techniques. We also have DNA detected by PCR, the DNA of leptospires. Well, for the presumptive cases, symptoms consistent with leptospirosis and any one of the following. So we have definitive and presumptive. So for the presumptive, presence of IgM antibodies as shown by ELISA or dipsticks, and the presence of IgM or IgG antibodies as shown by immunofluorescence assays. So in the early stages of leptospirosis, specifically the first few days, the most effective and reliable test is PCR or molecular testing. It is essential because it allows for a rapid diagnosis, which is crucial when time is of the essence. However, this isn't without its challenges. So, in restricted countries, PCR can be costly and requires specialized equipment along with technical expertise, making it less accessible. This lack often results in delayed confirmations of the disease in many endemic areas. And as the disease progresses, guys, into the second week, the focus shifts to serological. So let's start molecular, then it tends to become serological during the second week, shifting to the serological test, particularly the detection of specific IgM. And most of these tests, except for MAT, are feasible in a laboratory setting, and rapid tests can fill the gap when the lab isn't available. So understanding the timing and availability of these tests is crucial for proper diagnosis. So early in the disease, PCR, and later use we have serological tests, except math. So the most relevant test based on timing. So always remember timing is crucial for testing. So coordination between laboratory and physician is essential if the onset of illness is unclear, ensuring the right tests are selected for accurate diagnosis. So in the first week, serology tests have low negative predictive value, meaning a negative result doesn't rule out the disease. From the second week onward, PCR tests also become less reliable. So there's a low concordance between PCR, MATS, and ELISA IgM tests as they represent different disease phases. So first molecular, then in the second week you utilize serologic. So for treatment guidelines, recommend starting as soon as leptospirosis is suspected, ideally before the fifth day of illness to avoid delays in critical care. And understanding these nuances helps ensure timely and effective diagnosis and treatment, improving patient outcomes. So, doctors should not wait for laboratory test results before initiating treatment. So, thank you for listening and have a good day.